This is Dr. Amy Ho, host of ACEP Nowcast. Before today's episode, we want to remind our listeners that registration for ACEP's 2026 Scientific Assembly is now open. Your specialty, your people, one place. Join us in Chicago this October and register now at acep.org/ACEP26 for free access to ACEP anytime.
Ryan Stanton here with ACEP Frontline, today joined by Dr. Erik Blutinger, and good friend built up through the years, coming through IMRA and now a rising star within the American College of Emergency Physicians, representing the Northeast with New York. And welcome to the podcast. I think this is your first time on with us, isn't it?
It is. Thank you for having me.
I don't know why it's taken so long. First and foremost, kind of give us a little background on yourself.
Absolutely, I appreciate it. I'm born and raised in Washington, D.C., went to residency at Hospital University, Pennsylvania, moved over to New York City, worked at Mount Sinai and continued to work there, and got thrown into the flames of COVID-19. Have been practicing ever since, and since being at Mount Sinai, have worked on a number of different innovative care models, trying to always reduce the cost of care, but boosting the quality that we can provide our patients.
And this has been something that's been big for me as an EMS medical director, EMS boarded as well. You know, that idea of meeting the patients where they are. You know, the healthcare was traditionally the four walls of a large building, and the patient had to get to you, which is not always the best thing. What we're seeing now, especially with the evolution of technologies and just understanding the pathology of disease and the cost basis of the healthcare system, is looking for other options. So let's dive into some of those things of the idea of the evolution of meeting the patient where they are and evolving the four walls of the emergency department and hospital into something more expansive in seeing where the patients are.
That's a great segue, Ryan. I mean, I think you hit the nail on the head, that we traditionally have thought of acute care as being confined within the four walls of a department. But what we've seen, of course, since the pandemic especially, has been the explosion of new technology, new ways of thinking and new methods of really delivering care to the patient as opposed to waiting for folks to come in physically to an emergency department. It is critical that we really preserve the infrastructure and architecture that we have in hospitals and in departments. It's what we do. It's our bread and butter. It's also equally important to understand our role in the ecosystem of healthcare. And where the puck is moving, I would argue, in healthcare, is that in order to preserve value in medicine, it's going to be important to figure out more innovative ways to really drive home the value-based care argument. I think traditionally, so often as emergency room physicians, we are not thought of as a critical piece in the hub and spoke model for value-based care. But that evolution in thinking, I think, is starting to change. And there are a lot of ways in which we can make a dent in the equation. And one of them is telemedicine. Another one is community paramedicine. We can consider utilizing our care managers, our social workers, really understanding the care continuum of patients, and we are a critical piece of that.
I think the big consideration is understanding that our brains and talents as emergency physicians isn't contained within a four-wall department. You know, you see some of the things that we do, whether it's through EMS, whether it's through event medicine, whether it's through all the things that we do, the emergency medicine mindset translates very well to where that is, depending on having the right preparations, equipment, and whatever's necessary to provide that care. So talk a little bit more about how emergency medicine can lead the way with regard to some of these alternative care models and more cost-effective application of acute care.
Absolutely. There are a number of different ways. The first way is to be inspired and to feel like we can make a big difference. When I talk to new graduating residents from programs, they ask me, how do I get more involved in this space? How do I do more and be a part of some of the forward-thinking clinical solutions that we can provide the overall health ecosystem? And what I tell them is believe in yourself and believe in this specialty and being able to make a dent. We have been leading the charge. We've led the charge in telemedicine since COVID. We are continuing to do that. The second thing is understanding the problems. I never like coming to a discussion or conversation without understanding the root causes. Otherwise, we could spend all this time and forward thinking about solutions, but the solutions may not solve the problems that we're hoping to fix. And we know that avoidable, preventable ER visits can account for anywhere to upwards of 20% of national visits according to claims data. And we know that tens of billions of dollars every year are spent in the healthcare system on avoidable readmissions and avoidable ER visits. So understanding the problems, I think, is the second component to your question. And then I think the third component is understanding our resources and our supplies and what we have available to us in emergency medicine. We have an important seat at the table when we come to the conversation about utilization and understanding the cost of care. Inpatient visits per 1,000 members is a key metric that I know payers look at when understanding what does the utilization look like for their patient population and for their membership. And hospital systems all the time are looking at what is the utilization per 1,000 for ER visits in their patient population. So in order to help curb that, it's helpful on a given shift for a given patient encounter, not just looking at their acute care episode, but trying to contextualize their visit. Has this patient in front of me been bouncing in and out of ERs over the last 6 months? Have they been readmitted continuously? And if so, what can we do to not only treat their care episode, but how can we provide them some of the wraparound outpatient services so that they don't have to come back in next week or tomorrow, but can live a healthier and higher quality life out of the hospital for a longer period of time? We can make a big impact in that.
My wife does direct primary care, and actually this morning she was texting about somebody that she basically her goal was the return of the house call. And interestingly, that the malpractice insurance wouldn't cover unless she had an office. But this morning she was texting because she was draining an abscess at somebody's home that was infirm, that couldn't get out and about, couldn't make the appointment. But it prevents, a potential admission because, of course, once it gets bad enough and you start to get more systemic symptoms or more pain or, that can't be controlled, now you're in the hospital, emergency department, and prevents. And I think that's an opportunity for us. The reason she texted me is she's like, I wish you were here because you're a lot better at these types of INDs and things like that. Mm-hmm. And there is a lot of opportunity. What we found with our community paramedicine program in Lexington is that, a lot of the community paramedicines were setting up a very structured, this is what we're doing and this is how we're going to do it, and very structured. What we found with our community paramedicine was just leave the canvas open. Because what does that patient need? And what we found is that so many of the returns, so many of the calls were because of gaps within meeting the patient's needs, whether it's medications, whether it's transportation, whether it's understanding the processes, those types of things. And in their first year, they decreased our EMS call volume by 7%, which is basically an entire ambulance. So you can think about the millions of dollars. I think the estimated savings on the initial $500,000 grant was somewhere in the realm of $25 to $26 million that it saved to the people of Lexington and Fayette County. So let's kind of dive into that. How can these programs that you're talking about not only give opportunities for emergency physicians, give better outcomes for the patients, but also as an opportunity to go to the payers and saying, hey, this is better and saves money?
Mm-hmm. There are a couple ways to peel that onion, if I may, but I'm not going to cry on this podcast. I would say, for one, understanding our basic infrastructure. So we are the experts and masters of understanding that healthcare, it takes a team. It's a team sport. And community paramedicine, that you rightly mentioned, is one care model, that it's going to take an EMS team. It's going to take care coordination pathways. It's going to take a command center, if you will, or some folks in the centralized command office that helps set up appointments or unscheduled visits. So understanding our basic infrastructure needs is one. Two is measuring data. There are a number of studies that show how powerful community paramedicine can be. I mean, you mentioned a great one in your hometown. I'd say another one is in South Carolina. They did a study of an EMS unit that implemented a community paramedicine program. Within 72 hours of discharge, They targeted the patients at highest risk for being readmitted according to algorithms, which, by the way, have yet to be formalized even with payers. But they targeted this patient population. Within 72 hours, performed a home visit, and they found a drop of about 40% of readmission rates for this high-risk population over just 6 months of this pilot program. And that's just South Carolina. I mean, there are so many different papers and studies in different parts of the country. So understanding our basic infrastructure, measuring the data, and then really targeting the right patient population and tapping the right kinds of resources. Not every repeat visit or check-in visit requires a home visit. Not every check-in visit for a high utilizer requires a phone call. There is a hybrid, and it sits on a continuum, and really understanding your patient population in your geographical area of the country with the kind of resources you have available, ideally with a hospital or health system partnership, is what I would argue are ingredients for making that recipe of success.
And if anybody out there is interested in the community paramedicine piece, our particular community paramedicine group does a lot of education and helps onboard a lot of the new teams. But, you know, it's one of the big challenges we had was the fact that this was done by grants. We're all an urban county government, so it's the entire county, which in Kentucky all the counties are relatively small anyway. But the thing that lacked was the fact that, you know, if you're looking at this as a business model, especially for like private systems or whatever it may be, you know, the EMS system was not paid for non-transports. Of course, that's starting to catch up a little bit. So let's talk about some of those things that are lagging, those things that are going to be a hurdle to get over. And I think one of those major ones is going to be the payer reimbursement side of making this a functional piece of the healthcare system that in the end actually saves them money.
I totally agree. The programs that I have seen have failed in this space have been the ones that have thought too transactionally for their reimbursement model and think too much in the direction of fee-for-service. We are going to charge our partner this amount for this call, and we are just going to try to rack up the number of calls we have and generate as much revenue as possible. That hasn't traditionally worked in the last couple of years of this new care delivery model. What has been most effective is driving home this value-based care argument. We want to partner with you. Let's create some kind of a shared savings model. Instead of being rewarded or reimbursed based off per visit, let's work together and measure outcomes. Let's see if this particular patient with heart failure, if we run a checklist with them at home, we measure their weight, we make sure they have a cardiology appointment, we make sure that they don't have any falls, they've got the family support. We go through all these checklists, and they actually have a cut in their number of ER visits and inpatient visits over a 6 to 12 month span, and we can both share a bonus from that with the payer. Let's do it that way. I have found those kinds of arrangements from a reimbursement standpoint being most effective because it really coordinates incentives. And the alignment of incentives across payers, health systems, patients is what's often most tricky. The other thing I would say is we really need some regulatory certainty. There's so much regulatory uncertainty when it comes to telemedicine, when it comes to home visits. I know in my current New York state, there's a debate internally on whether or not scheduled community paramedicine visits should be allowed. And understanding what is allowed in community paramedicine and telemedicine is going to be ironed out over time, but because there's some uncertainty from the funding standpoint in Congress, that has caused a number, I know, health systems and potential partners to pause and to take a deep breath in understanding how they can financially plan over the longer term. And until that certainty comes, it is a little bit difficult planning out resources and mapping out budget for programs that wish to get started, at least in the long run.
We're sitting here at Partner Collaborative in Dallas, DFW, at the ACEP headquarters, and this conference, this get-together is the interaction between the organization, physicians, and the industry on how we can improve the lives and opportunities for physicians as well as the care of our patients. You know, right now I've got on an Oura Ring, I've got on the Apple Watch, just monitoring all types of stuff. I'm kind of addicted to kind of seeing what my body's doing, especially when I'm sleeping. how is technology advancing to really make a lot of this happen? I mean, I get patients quite often that said, hey, I got a call from the clinic because this thing I'm wearing told me this, and they said you need to get in right away. Usually that is, something with an arrhythmia or whatever it may be. How is technology going to continue to advance to make these alternative models more functional and more cost effective?
Technology is amazing. Without technology, I don't know what I would do in my day-to-day life. I will also argue that technology has to scale smartly and efficiently. And the reason for that is it has to be available to as many people as possible. Otherwise, the data that we acquire from the technology we're using will be more biased, I'm going to argue. It will be more biased towards certain patient populations that have access to that technology, but may not have as much need for the technology from the healthcare side as others who don't have the technology. What I'm concerned about, just to be a skeptic for a second, is this so-called concept of a digital divide. I want to make sure that whatever technology is out there and that we are using can be accessible for all. That is what you and I do and preach every day, right? We are 24/7, 365 for all patients, all shapes and sizes who wish to come into the emergency room. So what I hope is that for the new technology companies that are brainstorming ideas and coming up with new products and solutions, make sure that it's affordable and that it can be accessed whether you're in urban or rural settings, whether you are affluent, whether you require additional resources. Make it available to everybody, because that is what I think makes it more scalable and more effective. And then I'd also argue that technology needs to understand this boom of AI. AI, I think, is already revolutionizing the way in which we understand and interpret data, and technology is going to have to account for different ways of thinking. Now, I'm going to leave it purposefully vague because I'm not going to attest to being an expert in how that will change the way technology comes out, but I know that AI is here to stay, and I couldn't get through this podcast without at least mentioning that term. Otherwise, I may be brought out and behind the barn and shot.
Well, and hopefully it's not that, New York hasn't gone that old school, but it is, I mean, even right before we came up here, we were hearing about, the collection of data we have with our Data Institute, and the fact that until 2 years ago, or actually a year ago, the data was too complex, nothing could sort through it. And now all of a sudden we've got AI-based tools that now can sort that data, and we're actually building research based on the millions of patient data so we can build EM base. I mean, so AI is already impacting, it's evolving so quickly. The challenge for us is the human side of things is to put up the appropriate guardrails and to guide it in the directions that are best in terms of benefiting patients, while others are using it to negatively impact these systems, such as some of the payers. But there's a lot of opportunity, and I think that's going to be definitely the conversation over the next number of years. So how can folks get in touch with you? Talking with Dr. Erik Blutinger here, future leader, actually current leader within the American College of Emergency Physicians, but probably going to see him in my chair at some point in the next 10 to 15 years with this, and look forward to that. Somebody we've looked up to and been a great partner with ever since even back in the resident days.
It's been great. It's been a great ride.
Nothing, yeah. And how can folks get in touch with you? Any questions?
Please email. Feel free to also call. I'm happy to share my cell phone number in whatever way possible. But if you do have an idea, interesting concept, interesting thought-provoking study, or any way in which you wish to pivot and revolutionize and innovate the way care is delivered in emergency medicine, I'd love to hear from you. This has been an amazing ride. I only finished residency in 2019, and I just feel more inspired than ever to continue being in emergency medicine because of all the innovation and the opportunities that we have to make an impact in different patient populations that I never thought would even be possible.
Well, I appreciate your time. Thanks for sneaking up here to the Blue Sky Room and having a chance to chat about it. And I'm glad, hopefully this is the first of many opportunities on the podcast. Thank you. As for me, rstanton@acep.org, rstanton@acep.org. Check us out. Make sure that you got us downloaded and saved on your favorite player. Give us a 5-star review, please. That helps boost us up in the list and helps others find us. And also, word of mouth and your recommendation helps as well. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
And in the silence, you will show me who you are.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Dinger. Quiet place, all
Yeah.
alone. Da, da, da.